to join, then we can start. Okay, for the sake of time, we only have 45 minutes. I'm starting our session today. So this will be another English version. And again, this will be also on YouTube for those of you who cannot actually join tonight, or you can let your friends know. So let's start with the first slide. And also, again, if you want to have any questions, and you should actually participate by sending a message through chat window, actually, that would be preferable. Then, you know, this really helps me to guide, you know, the seminar. So this is starting with a patient, as you see on the slide. It's a patient, looks like a Holter, right? 3-lead Holter, quite irregular looking rhythm. And so let me see your remarks. What do you think about this? What you see on this page? Okay. I'm waiting for any answer so far. Just use the chat window, preferably. Okay. Some of you say 6 sinus, some of you say complete AV block. Again, use the chat window, please, not the question and answer area, so that we don't have to look to different places. Okay. Venkeba, sinus node dysfunction, and idioventricular rhythm, 2 to 1 AV block, all these different things. So one thing I want to point out actually is that if you look at the page, you will see this blue spike, right? Looks like potentially a pacemaker, and the QRS here is different. So I want you to point out to this place because, you know, this patient may have a pacemaker, right? So the way to understand actually, obviously, you should know whose Holter is this? Does this patient have a pacemaker? But if you just look at this page, and okay, we will comment on this part of the rhythm, but if you look at this QRS being different before this spike, okay, there's another spike here. The QRS actually is not different, but there's another one at the end, a third one. Again, this looks like the same QRS. So actually this patient looks like it has a pacemaker, right? And again, starting from the beginning, I think you clearly see the P waves, okay? They seem to be associated with the QRS here, although as you see, the PR is prolonging, okay? So most likely they are associated, and actually what's happening is PR prolonging, so in a way it's trying to do Venkeba, and then this P actually drops, right? And then next P actually, whether conducted or not, actually didn't have a chance because we have a pacing spike, okay? And then we have another narrow QRS, and if you look at the T wave here, it's quite actually spiked. You know, this is very unusual for a T wave. You see the same thing here. So there's a P wave here which is conducted, okay? And then next one looks like the same baseline QRS, okay? So therefore, actually it is conducted again, all right? Even though there's a pacing spike. So when there's a pacing spike, actually, if it comes on the native QRS, it wouldn't capture. So that's not a problem. And then continues with first degree AV block. Actually looks like first degree, but then it's prolonging. And then again, one beat drops, and then another pacing spike, which captures, okay? And if you notice actually the duration of, the timing of the pacing, it's about 1,250 millisecond, right? Roughly. If we had a caliper, it would be the exact timing from the QRS. So that would come to a rate of about 45 or so, right? So this patient's pacemaker probably set at that rate. So what do you think? This pacemaker is what type of pacemaker is this? Is this a single chamber, dual chamber, a CRT, atrial, ventricular? Any idea? So is it DDD, VVI? Okay. Dual chamber. Okay. I think really the main question is here, obviously it's not atrial pacemaker. Is this a ventricular pacemaker in, like a ventricular pacing only? Or is it like dual chamber pacemaker, right? So if this was a dual chamber pacemaker, what you would see, I think it may be difficult to comment on this part because maybe it's atrial sensing ventricular pacing, right? We don't know. We don't know what the AV interval here is. But what's unlikely is that if this is the AV interval here, sensed AV interval, let's say this one is much shorter, okay? And you see the spike here, but still there's an A and then paced QRS, right? So hard to say, but if you look at the last one, the very last one, again, it does the Vankaba. Before any P comes, what you see actually is a paced QRS, okay? So where is the P here? There's no sensed P and there's no actual paced P. So therefore, this is actually a single chamber ventricular pacemaker. This is how you can tell. There has to be a P wave before this, either sensed or paced. Again, assuming normal pacing function, no oversensing, anything like that. Then there should be a P wave here of some sort, either sensed, intrinsic, or paced to say it's dual chamber. So therefore, it's a single chamber. And most likely the mode is VVI and it's set at a low rate like 50 or 45 beats per minute. It only comes into action when there is a long like a duration, like here and here and here actually. Looks like it's 12, 15 here milliseconds. So it must be 50 beats per minute, the low rate. So most likely this is set at VVI 40 beats per minute. And this patient actually looks like having Vankaba type of block. And to avoid constant pacing, the pacemaker is actually in VVI mode and only comes into action when actually there is a pause like this. Otherwise, the patient uses his or her own conduction system. This is next page on the same patient. As you see, again, no P before the QRSs, and again, 50 beats per minute, as you see here. But then here, see, this one conducts, and therefore, before any pacing comes. And then again here, this QRS is like in between, right? Not like the pace QRS or not like this QRS. So therefore, this is a fused QRS actually. This actually comes about the same time as the junctional, looks like in this case. That's why it's looking a little different. So the assessment of, Holters in somebody with pacemaker can be quite complicated, and you have to know the mode. You have to know lots of things about the pacemaker to have a reliable, actually, assessment on the Holter. So the location of the pacemaker, obviously, hard to say. I think somebody asked about the location. If you're asking about the lead, I mean, this is ventricular. We cannot say which one. But if we assume this is V1 through V1 and V5, it's all negative. So somewhere in the apex, hard to say it's right-sided or left-sided. The other comment about DDD had been better. I don't agree with this because there is always a reason behind. I mean, if this patient requires only 10% of pacing like this and has a normal function and is a small child, rather than putting two leads, putting a single lead and VVI is better than actually a DDD pacing. A DDD pacing in this patient would result very frequent ventricular pacing, which wouldn't be appropriate. But there's a dual chamber pacemaker mode in some pacemakers, like Medtronic's pacemakers especially, has MVP mode, where you can have, it's called managed ventricular pacing. You can avoid unnecessary V pacing, but basically in a patient who requires less V pacing, like this one, it can be appropriate depending on the patient. Again, some patients would benefit more from dual chamber, some patients you don't need to. All right, so next one, let's go to the next patient. Actually, this is the same patient, you know, with the same, as you see, this patient is having lots of intrinsic rhythm, some junctional, some conducted P waves. When the rate is over 50 beats per minute, there's no pacing coming in, right? All right, again here, similar. All right, next patient is looks like an 8-year-old, and this is from an EP study, okay? Based on the tracings of the previous pacing, we cannot say epicardial or transvenous. So 8-year-old patient, this is from an EP study actually. If you look at it, the first 4 actually tracings belong to surface QRS, 1, 2 AVF, V1, V6, and rest actually intracardiacs. There's a coronary sinus, it looks like there's another catheter here, and then there's RV catheter. And actually what's happening here, let me help you. We are actually pacing the atrium from the coronary sinus, okay? So when we pace the atrium, you see we are pacing really fast. Actually, what we are trying to do here, maybe you notice from the surface, what does this patient have? If you look at the QRS at the beginning, what do you think is a diagnosis? WPW, right? Very good. So this patient has WPW, and this is why the QRS is wide. And what we are trying to do is trying to assess the shortest pre-excited RR interval. We call it Sperry interval to assess for the risk of this patient, right? So this is one of the things we do. We measure the effective refractory period, ERP of the pathway, and we also induce atrial fibrillation to see how fast this pathway would conduct, even before all ablations, because, you know, if the, okay, all these patients require ablation anyways, but if it's a high risk, our approach can be different. And we need to know, in case there is recurrence, whether this was a high risk or lower risk looking pathway. Although in recent years, we believe that assessment like this actually can actually not be as sensitive as we think. But if you show that it's really high risk, then it is high risk actually. So here, this is, you know, what's happening. Actually, if you see, we are pacing the atrium really fast, okay? And then atrial fibrillation, as you see, is here induced. And what we don't want to see is fast conduction down the pathway. And actually, this is what we see. You see 180, 190, this is milliseconds. So this patient is going down the ventricle about 300 beats per minute, and can easily go into actually VF or, you know, ventricular flutter or VF with this rhythm. And then we shock by giving a synchronized cardioversion here, in this case, into sinus rhythm. And actually, as you see, the this is how we assess these patients, by inducing atrial fibrillation. And you can have surprises. Sometimes patients have only mild pre-excitation, and when you induce atrial fibrillation, they go into like VT and VF, and this can be really dangerous for these patients. Okay. So I want to show these strips, like how we assess, you know, WPW in the EP lab before any ablation. Here is another patient, actually. Let's get your opinion about this. What do you think about this ECG, 12-lead ECG? Okay, is it better? I think you had difficulty seeing my screen. Can you see the whole screen, like the ECG? For example, in this case, I just want to make sure. Okay, good. So, yeah. All right, so some already mentioned there is pacing here, right? So what type of pacing you see here? Is it atrial, it's ventricular, it's dual chamber? What do you think? Okay, so if it's atrial pacing, why is the QRS wide? And we have to look all actually leads, right? I really don't see spike also, like I agree with you. I think it's only atrial pacing, right? Like most of you said. You see nice spikes before the P waves, but you have to look carefully because sometimes the spike is so small, you may not be able to see it well, but really it's a clean 12 lead ECG, and I don't see any spikes. And this is a right bundle branch block. So this must be a patient who had some sort of operation and not AV block, maybe sinus node dysfunction and having atrial pacing. This doesn't mean this is not dual chamber. It may be dual chamber. Maybe the patient initially had only sinus node dysfunction and has a dual chamber still, or maybe it's single chamber. We don't know, right? And actually, or, we see this sometimes. Patient have, we implant the dual chamber pacemaker, but then after the operation, weeks, months later, the AV conduction recovers and you have normal conduction. And so we cannot say it's dual chamber or single chamber based on this ECG, but what we see here is atrial pacing and right bundle branch block, okay? This is same patient. What is different here? It's just the same patient. All right, yeah. So, okay, I'm getting some responses already. Any ideas? Okay, most of you responded so far say it's atrial tachycardia or atrial flutter. Actually, you're right. I'll tell you the reason I showed you this. This is the same patient. Let's say we do a pacemaker assessment on this patient, right? Let's say we interrogate the pacemaker, we check the, the rhythm or whatever thresholds, especially ventricular, everything may be looking fine, but suddenly you go into this rhythm, the pacemaker still may be functioning fine, but indeed here you have something different. You have atrial flutter, and this could have been atrial fibrillation also. So in this patient, it's easy. Why? Because this patient has normal conduction down the AV node, right? So when this patient goes into atrial fibrillation or atrial flutter, you will have a fast response. As you see here, variable AV conduction. And actually, with that, actually, you see that in between the flutter waves, right? If you look at these PV to P interval, I'm just zooming on it, it's almost like 300 beats per minute, right? So, so it's easy. But if this patient was being paced ventricular, right, you would have difficulty saying sometimes, especially in atrial fibrillation. The rate, the ventricular pacing rate may stay the same if the patient has AV block, and atrial, channel may actually not be obvious to you. And the patient may be pacing regularly, when I'm talking about ventricular pacing, and patient might be in atrial fibrillation. So you have to be very careful in assessing 12 lead ECGs, especially in patients with AV block, okay? So let's say the patient has a single chamber ventricular pacemaker. You may have normal, threshold, normal ventricular lead impedance, everything might be looking normal in let's say it's a single chamber pacemaker, right? Or even, dual chamber. You may not actually appreciate the underlying rhythm in the atrium. And it is important because that's sometimes something people can miss. So always it's a good habit to comment about atrial rhythm. For example, when I do read ECGs in these patients, I say, okay, I say this patient is a pacemaker, I say ventricular pacing, and I say atrial rhythm is sinus, or atrial rhythm is not obvious, or like flutter in this case. So you have to say something. Think about atrial rhythm also, even let's say the patient has actually a single chamber ventricular pacemaker. You have to think about the atrial rhythm. Because if you miss, it can lead to thrombus formation, thromboemboli, even stroke, right? It can be really dangerous. Okay, let's look at this different patient. So it looks like there are different colors. Some conduction, then there's some green ones, and there's some red ones. Okay, what do you think about this rhythm strip? Obviously, this is a different patient. Okay, waiting for your comments. Okay, some people say PACs. Some people say atrial bigeminy. PAC, okay. All right. So, I mean, the discussions between PAC, Vancaba, Mobitz type 2, some sort of AV block, I guess, and ventricular escape. Good. So basically, these are all possibilities, right? So we have to sort out what it is. To call something PAC, again, I always remind this to our people, I mean, cardiologists or whatever in this case, that you have to think about the, like the terminology, like PAC is premature, right? So it comes early. So it comes early in reference to what? In reference to the sinus. So if you say PVC, it means there is a ectopic beat from the ventricle that comes relatively early compared to the previous QRS. So PAC has nothing to do with the ventricle, and PVC has nothing to do with the atrium. So you have to remember this. So when you see something early, it has to be early compared to the baseline sinus rhythm for a PAC. When you want to call something PVC, it has to be early compared to the native QRS or intrinsic QRS. So let's look at it. Looks like we see some early looking P waves, right? But again, early looking because it's shortly after QRS. That doesn't qualify for PAC, right? You have to look at your PP interval. Like if you look at your PP interval here, little over, it's about $2 maybe. You'll see that it's the same actually, okay? Let's assume you put a caliper. You see it's a little bit 2.2 bucks maybe, okay, like 22 millimeter maybe. It looks the same throughout. And not only that, even the morphology is the same. So therefore, you can easily conclude, if you look at this like that there's no actually early P wave here. The P waves, again, in reference to each other, either PAC or normal. And this is normal sinus rhythm, okay? And of course, the rate is not 77 because some of them are blocked, right? We will look into this separately. So first of all, we need to identify that this is not a PAC, okay? It's a sinus because it comes in expected time with the same morphology. Okay, why is it early then? Actually, it's not early. What's happening here is it's not conducting. This one is not conducting normal. It's conducting really long, okay, longer than before. And actually, the next one is even not conducting. So it's blocked. So that's a typical Vancaba behavior, what you see here. So prolonged PR, and next PR is shorter, okay? Again, 3 beats, third one blocked. Next PR is shorter. Same story. So what happens here? This is a little different, right? So this PR, and then we have a P here. And most likely what's happening here actually is a P wave conducting, this time with some aberrancy. So most likely this is not a PVC. It's aberrantly conducted sinus P wave because this P wave came relatively early to the previous QRS, okay? So that's why the QRS morphology is different, especially more different here. So most likely this is conducted, not a PVC, because there's a P wave before. It's all about timing of the P wave. Slightly earlier may give you some aberration. You may not have aberration all the time, like you don't have it here. It's not Mobitz type 2, therefore. It's Mobitz type 1, right? Because, again, it's prolonged PR and one piece dropped. So some of you saying, could it be Mobitz type 2? This is why I made that comment. For Mobitz type 2, the PR would be fixed and the 1P would be dropping. This PR is much shorter than this one, and that's why it blocks. Okay, here, you don't have this chance. Actually, there's another P here, if you pay attention. PR, and this P drops, okay? So again here, 3 beats like that. So it really fits to the first type or Mobitz type 1 AV block, okay? So yeah, when the T's are on P, it can be confusing, but again, if you use a caliper and if you pay attention, you have the same morphology coming on at the expected time, okay? All right, next one is a different patient. All right. Let me get your opinion about this. All right. WPW. All right. But, okay, I guess there is a consensus. There's a consensus. Okay, good. I agree. Nothing unusual. Same patient. What is different? Okay, subtle pre-excitation, because it's not obvious. I mean, it is obvious, but it's not that much. So it's a minimal pre-excitation. So we call this subtle pre-excitation. Same patient, different part of the Holter. So what do you think about this one? More prominent, right? So there is variability of pre-excitation. Just like intermittent pre-excitation, there are a few things that you can see. One is, you see here, the pre-excitation throughout the Holter can be variable, less or more. Two, pre-excitation can be actually intermittent, right? And the other thing is pre-excitation can be changing in morphology, which indicates actually another pathway. So we have to pay attention in the Holter, not just say, okay, this patient has WPW. We need to, like when we look at the Holter on a patient with WPW, we need to say, you know, it's persistent pre-excitation or not? Is it disappearing with sinus tachycardia? Is it intermittent? Is it, if it's intermittent, is there a sudden change? Is there a change is a big change in the morphology in the pre-excitation, which may indicate more than one pathway? So all these things we have to pay attention. All right. Next patient is a different patient. So what do you think about this? This is real rhythm. First of all, it's not actually, it's not actually artifact. For the previous one, there's a question whether the PR was normal. Yeah, and PR may look normal, but there was a very obvious pre-excitation, delta wave. Okay. Okay, general consensus is torsade de pointe. Okay, now I want you to pay attention to, I want you to divide the rhythm strip in half. Look at the first half and second half. Do you think there's a difference? Excellent. I'm getting some very nice comments. So some say first part is different than second part. Okay, let's focus on the first part, okay? If you see a patient with uniform looking, like white QRS tachycardia, uniform looking, but in general very irregular, always think about atrial fibrillation and WPW, okay? So we call it pre-excited atrial fibrillation, all right? And actually, this is what's happening here. This is atrial fibrillation, and it's going down the pathway, obviously with irregular intervals, like the patient I just showed you like 5 minutes ago. You know, we were inducing atrial fibrillation, right? Very fast QRS, irregular, and same morphology. And it's degenerating into a different rhythm. Now, here it's atrial fibrillation, here it's ventricular fibrillation. This is how these patients die, actually. You know, if they go into atrial fibrillation, they can conduct really fast. And also, I want you to, I just would like to actually point out the misconception. People think that, you know, the patients with WPW, they are not having SVT, maybe they are not at much risk, which is not true, because SVT mechanism has nothing to do with atrial fibrillation mechanism. So a child may have less or more pre-excitation, doesn't mean during atrial fibrillation they will have you know, less conduction. It won't be like this. No, it's not true. I have lots of patients who actually have only mild pre-excitation and who never had any SVT in their life. And when we induce atrial fibrillation, they look like this, okay? So therefore, this is why it's very important, like the guidelines say in American Heart and in general throughout the world, accepted, you know, guidelines after 15 kilos, so 3 to 4 years of age, regardless of their symptom or SVT, regardless of what type of WPW, they all need some sort of EP study and most likely ablation, okay? Because you never know which one is worse than other without doing an EP study. All right, so let me see. All right, This one, I will help you a little bit. This is a patient with dual chamber, or let me see. Let's put it this way. This is a patient with pacemaker, okay? And possibly dual chamber, right? Because you have A and V associated to each other. And there is ventricular pacing here, all right? So just pay attention to this slide. I go to the next slide. All right, let me go before. This is after. Before, after. Meaning actually it's all the same Holter, all right? So there is some change. And what do you think about this change? And what could be going on here? There's one more slide. No, this is no, actually 2 slides only. So what's going on here? Why is the QRS changing? Right, that's what you're noticing. As you see, there's still P waves before the QRS at the same timing. So it looks like it's probably atrial sensing and ventricular pacing. But why is this QRS changing? Okay. So some people say, could it be fusion? Okay. For fusion, you have to have an intrinsic QRS, right? A normal QRS plus the ventricular pacing coming about the same time leads to a different QRS, which is possible. But if you notice, this PR is really short. For this patient to have this short PR interval and conduction like this is unusual, because then are we pacing this patient unnecessarily? I mean, if this patient is able to conduct with this short PR interval, meaning there's an intrinsic QRS here, why are we pacing this patient, right? But theoretically, it's possible, but it's very unlikely. Let me tell you, this patient has AV block as baseline. This patient doesn't have AV conduction, let's say. Okay, so some of you already responded well. So I'll just repeat that. This patient has actually CRT, okay? CRT means you have atrial right and left ventricular leads, right? So when you're pacing the ventricle, you're pacing both LV and RV. Could be different timings, could be equal time, that's a different story, but you're pacing them pretty much the same time. So if actually you see this type of QRS change in a patient with CRT in a Holter, what does this mean? What do you think this means? Accessory pathway, again, if the patient doesn't have AV conduction, it cannot be accessory pathway, right? There's no conduction. Bundle branch block, again, no, because the patient has AV block. Excellent, yes. Yes, ineffective pacing. No, actually, a problem with pacing, right? In summary, so you're pacing, but you're not capturing the same. So if you see a different QRS, when you have a patient like this with a CRT, you should think about loss of capture in one of the leads, okay? So this patient probably either RV lead or LV lead, whichever one, is not capturing normally and intermittently losing capture, and you're left with only one lead capture. This is why it's important that when you're checking the Holter in the patients with CRT, to know whether both ventricular leads are working fine, you need to see the same QRS. If you're seeing the pace QRS morphology changing like this, this may be indicating intermittent loss of capture with RV lead or LV lead. And actually, obviously, this is not a good thing. First of all, it indicates a lead failure, or maybe you need to adjust your threshold. Maybe you need to increase your, capture threshold. But it may also indicate intermittent, lead fracture, partial lead fracture, which may show up like this. So your pace check may completely show normal findings, normal impedance, normal threshold, but you may capture these things in Holter. This is why I routinely do Holters in my pacemaker patients pretty much in most once a year, sometimes every other year. If actually the patient is dependent on pacing, so there's no underlying rhythm, definitely once a year I do Holters, because I did catch a lot of patients lead issues despite normal pace check on the Holter by loss of capture or by inappropriate sensing or whatever. And you may need to do something about this, obviously. So that's why when you look at a pacemaker patient's Holter, you have to pay attention to all these little but important details. Okay. Here's another patient. This one doesn't have a pacemaker. Okay, let's see what you think. All right, any comments? PACs, some people say PACs. PJC is another comment. PJC, what is left? I mean, PAC in Bigemini, okay. And PVC, okay. I think the other thing left is artifact, right? So you said all. Let's find out which one. Okay, so this is sinus, right? And then do you see a P wave? I don't. It's a very clean segment in all three leads. And actually, the QRS looks very similar, but it's not completely the same, okay? But still, it looks quite similar. So if somebody calls this PJC, I wouldn't say it's wrong. But without seeing a 12 lead or looking deeper, I wouldn't say definitely this is a PJC, because the QRS is slightly different. I mean, if you pay attention. Okay, but not too much. And there's no P wave before. Therefore, since there's no P wave, I mean, it has to be PJC or PVC, and it comes early. And actually, there's a small deflection which actually indicates a P wave here, all right? So therefore, this is either PJC or P. How we differentiate? You need a 12 lead. This is the part of the help with the 12 lead Holters. And, this patient had a 12 lead Holter. And look at this now. You see this QRS is slightly different, especially lead one is so much different, right? Look at this one versus this one. And some subtle differences in others. Look at the precordial leads. It's so much different, right? So then it cannot be PJC, right? Therefore, it's a PVC, most likely fascicular type of PVC, but it is a PVC. So sometimes you need a 12 lead to be able to say. Okay, very good. Let me see. Again, same patient, but on 3 lead Holter. This time, this is a ventricular couplet, right? But without 12 lead, we wouldn't be able to say. So what's happening here? This is marked as atrial couplet, but now you call it ventricular couplet, right? Do you agree? Now we know this QRS is different. What do you think? So what is this? Is this same patient again? Is this a ventricular couplet? Or is this sinus capture, or what's going on? Retrograde? Okay. All right, PAC, right? Very good. So again, we go to our basics. We go to our basics and take it from there. So first of all, this is sinus rhythm, right? And then I don't have a P wave. I have this QRS. Without 12 lead, I wasn't able to say it's PJC or PVC, right? But then we decided that actually this is a PVC. And if you pay attention, there's an R prime here. Let me zoom. This R prime, hard to see because of this big QRS voltage here, but we identified this beat as fascicular. It's a different QRS on 12 lead. But if you pay attention to this middle lead, there's RS, but there's no R prime, okay? See, there's no R prime. I'm continuing, and there's an R prime here, okay? So this is our fascicular PVC, or, PVC. All right, then what do I have? Clearly, there's a T wave, and looks like there's a P wave on top of it. There's no such T wave, of course, right? So this is there's a P wave here, and then there's another QRS. Okay, so is this fascicular also? Let's look at this. So if you look at these three QRSs, this QRS actually looks like the baseline QRS, this third one. Okay, just pay attention. You don't have this negative segment okay? There's no R prime here. So that's like a baseline QRS. That's like a normal intrinsic QRS. So therefore, this QRS is a result of this P wave. Therefore, this is not a ventricular couplet, okay? So that's our first result. So therefore, you have a vesicular PVC, you have a PVC, followed by a P wave that's conducted, okay? Now, our next analysis is, like most of you are saying, what is this P wave? Is this PAC or not? Again, what did I tell you before? To call something PAC, it has to come relatively early compared to what? QRS? No, it has to come relatively early compared to the previous baseline sinus rhythm, okay? So let's look at it. What is the rate on this patient? Looks like 718 milliseconds, right? Slight irregularity, sinus irregularity, which is okay. But approximately, if you look at this, 1, 2, 3, 4 big boxes, 1, 2, 3, 4, roughly 4 big boxes, okay? 1, 2, 3, 4 big boxes, and you have a P wave. 1, 2, 3, 4 big boxes, you have a P wave. And actually, this is sinus, okay? So your sinus comes at expected time. Again, sinus node doesn't know what's going in the ventricle, right? Has no idea. As long as you don't have like retrograde conduction, like this P wave, this QRS, sorry, doesn't have retrograde conduction. Yes, it's a PVC, but you know, since there's no retrograde conduction, atrium doesn't know what's going on in the ventricle, right? So the sinus comes at the expected time. When you put a caliper, you will see. And next one also expected time. So there's no PAC here. This is sinus. And actually, this is a sinus capture beat. Okay, that's a sinus capture beat. So what you see here in summary is a PVC followed by a sinus capture beat. Very good. So if you look at it like in detail like this and think about your terminology, what does it mean? You'll be able to differentiate all these things. And actually, this is the 12th lead representation of the same segment here. This is why 12th lead Holter is really helpful if you're not sure about a patient, you know, having, PVC or not. And actually, if you have a 12th lead Holter, I recommend you to use it, especially for assessment of PVCs. And again, this is the 12th lead part of the same strip. You see, this is a sinus P. This QRS is same as baseline, okay? And like, look at this QRS versus this one. This one is our PVC in the middle, okay? Like this one. So therefore, it's not a PAC. It's a PVC, and this is sinus capturing normally, okay? There's no PAC. This P comes at expected time, and actually even the morphology is the same. This comes at the end of the T wave. You look at this, is the same P wave as here and expected time. So this P didn't come earlier than the expected sinus. Any PVC, okay, one question is how the PVC is not white, okay? Anything not intrinsic and different morphology is a PVC that's coming early, right? So look at this. This QRS is just slightly wider, not too much, but that's enough. Vesicular PVCs are like that. They are not always that wide, but they are always a little bit wider, right? So this is your baseline QRS, and this is your PVC. And not all leads can represent this. For example, inferior leads, it doesn't look that wide, right? AVR, it looks a little bit wider, but the precordials look a little bit wider. So it doesn't mean, it doesn't have to be really wide to be a PVC. As long as it's not like the baseline QRS and a little bit wider, this is enough, okay? All right, next one. It's a different patient. Vesicular PVC. Most likely the left ventricular and its inferior axis, so left anterior vesicular PVC, most likely. Almost for certain, actually, when I say most likely. All right, so sinus, and what happens? There's a tachycardia here, right? Some sort of tachycardia. Is it narrow or wide QRS? After the last one, of course, you're looking at more careful, I'm sure. But, you know, do you think this QRS is different? Probably not, right? It looks the same. So it's a narrow QRS tachycardia. So it looks like an SVT, actually. a non-sustained SVT. All right, good. And the rate, is it regular? And rate, it's irregular actually, right? Okay. So how does it start? Let's look at it. Let's zoom on it. Sinus, sinus. And then what happens? Sinus normal, sinus QRS. Nothing, right? No P wave on all 3 leads. So it looks like a junctional beat and irregular rhythm. And even more, if you look at this one especially, you see some on the 3rd lead also better. There are some P waves that look, that seem like they're coming at different times, like maybe here, okay, and very irregular. So actually this is a non-sustained jet, right? This is junctional ectopic tachycardia with irregular, actually, retrograde conduction, most likely, not consistent conduction, and actually just jet. We call this jet. Yes, it can be sometimes junctional. Why is it not focal atrial tachycardia? Because it's not a P wave that's starting it. It's a junctional beat. It's actually, and next one is also junction. So that's junctional tachycardia, not atrial tachycardia. Otherwise, you would have a P wave here coming early, not like P of the sinus. It would be early, and most likely it would be a different shape, and that would actually lead to PQRS, you know, kind of morphology or sequence during tachycardia, and then you could have called it possible focal atrial tachycardia. But this is junctional ectopic tachycardia. All right, let's do 2 more patients, and then we'll be finished. What do you think about this rhythm? Okay. Any idea? It's irregular, right? It's irregular. All right. Look at the rhythm strip at below. Maybe that's more helpful because more continuous strip. Okay. Here are the comments. Morbid type 1 AV block, question of morbid type 1, focal atrial tachycardia, all this. Vancomycin. Vancomycin and morbid type 1 is the same. Atrial tachycardia, paroxysmal atrial tachycardia. So I don't know the age of this patient. It's not written here. First of all, if you look at the P waves, like these P waves are looking like sinus morphology, right? And I mean, in terms of morphology. But how about the rate? Okay, let's look at the rate. So if you look at this, you have like maybe 2.5 boxes, okay? And then this one is like 3.5 bucks. This one, 1, 2, 3, 3 bucks. 1, 2, 3, okay? So it's slightly irregular, okay? 1, 2, maybe 3. But the morphology is the same. So hard to say for sure, but could it be like non-sustained atrial tachycardia? But it could be sinus arrhythmia also, right? But if you look at this again, 1, 2, almost 3, seems like it's a little bit faster here, this PP interval, compared to some areas. So either there's some atrial tachycardia, but there's a good chance that this is only actually maybe a sinus, irregular sinus. So if you look at the different leads, we're trying to find out a hint. And then if you look at the lead 3, one of you is actually pointing out, maybe the P wave is negative, right? But it also comes on a T wave. Hard to say for sure, but likely that these are short runs of atrial tachycardia. Regardless, what you see here is that it's leading to a Wenckebach type behavior. So most likely what's happening here is you have sinus and short run of atrial tachycardia, but not very fast, and one is blocked, okay? So if the PP interval was fixed, then for sure we would say this is Wenckebach with sinus. But looks like these P waves are slightly different, okay? So sometimes you can have combination of these things. You can have both AV block, first degree AV block, or, you know, Mobitz type 1 is here and non-sustained lines of atrial tachycardia. Let's do this patient and then finish, okay? It's already 9:05. We started a few minutes late, so that's why I'm making up this part. Okay, let's make it easy. This is white QRS tachycardia, right? Rate 236 beats per minute, maybe. So what do you think is the diagnosis? So if somebody shows you this and tells you, what do you think about this rhythm? What would you say? Without any other additional information. Okay, VT, SVT with aberration, atrial flutter, VT. I'm just reading out, aberrant, VT, okay, treat SVT. The question is, what do you think? Okay, white QRS tachycardia. All right, so this is what I would say. If somebody shows me this, first of all, I cannot say anything about P waves, right? How can you say P waves here? I cannot, because it's just white QRS, that's it. So we never call this VT, and we never make up things like SVT with aberrancy or whatever. To decide, you need to do some things like vagal maneuver, adenosine, baseline QRS during sinus. You need to see these things to decide, right? You need to see whether it's responding to adenosine and all these things. Otherwise, this is white QRS tachycardia. And it's quite fast, actually. So, and then continuing rhythm strip. This was from a Holter, same patient. And things change. Okay. Now, does this help further in your diagnosis? See, now we have more information. White QRS tachycardia changes, something happens, and then it stops, right? All right, so now maybe we can say more. Was this VT? No, right? As some of you are already saying, no, because you end up in what? Narrow QRS tachycardia? So if white QRS tachycardia turns into a narrow QRS tachycardia with same rate, we call it aberrancy, right? Aberrant SVT. It's not VT, we say it's aberrant SVT. But let me tell you something. This tachycardia here is also white QRS tachycardia. Actually, what you're seeing here is one form of white QRS tachycardia turning into another form of white QRS tachycardia, and then it stops. Okay, this is, you have to read what you're seeing. But I agree with you, this is SVT. Why? Because the second white QRS tachycardia, right, is white QRS tachycardia because you see the baseline, this patient is bundle branch block. It has the same morphology. Therefore, this is SVT, not VT. Since it's similar to sinus, bundle branch block, this is bundle branch block, SVT with bundle branch block. So it's still white QRS tachycardia. But since this is SVT and the white QRS tachycardia preceding, without changing the rate, I mean, it can change a little bit, but in general, about the same rate, same tachycardia rate almost, changing into this form, which is the same QRS as baseline, you see the baseline here, makes it actually SVT. So therefore, let's look at it again. If somebody asks you this, you have to say, I have no idea. If the patient is hemodynamically very unstable, you have to shock, right? If you have a little bit time, best thing to do is vagal maneuver, or really ideal thing to do is adenosine, okay? But while waiting, you see this tachycardia changes to this type of QRS as baseline. So therefore, this was SVT actually, SVT with aberrancy, right? If it was VT, it wouldn't convert into the same rate SVT. It's almost not possible. So therefore, this was actually SVT. This is like unzoomed version, pretty much showing the same thing. White QRS tachycardia changing into another white QRS, which is the bundle branch block of the baseline. Okay. All right. So we end here. And again, hope to continue next week with the Turkish version of the same lecture today, and 2 weeks later, as actually outlined on the flyer. You know, we sent you something that gives you dates. If there's any cancellation or any changes, we'll try to notify you a day before. Thank you very much again for joining. Have a nice week and take care all. Bye-bye.